So most of the trauma that we see, about 80% that we see in the UK, is blunt. So that's things like punches, road traffic accidents, whereas penetrating would be things like bullets or stab wounds. And it can be clinically significant, but it's quite often missed because patients who, for example, come in with a big road traffic accident may well have had blunt trauma, but the issue is that they have often other things going on. For example, they may have hurt their head, and clinicians often end up getting sidetracked. So one of the consequences of blunt abdominal trauma is hollow viscus and mesenteric injury. So a hollow viscus is just anything that's hollow inside, so something like the bowel. Mesentery is what we've just been talking about. And the most commonly injured part of the bowel, the mesentery, is that is related to the small intestine. And that makes about 70% of cases. There are several different mechanisms by which this happens. The first is obviously the blunt trauma itself can damage structures. Second is that we get shearing forces, and this is essentially where there's a patient who's, for example, been in a car, it stops very suddenly, they stop and their organs keep going. And because of that rapid change in acceleration, deceleration, it ends up tearing bits apart. And it's also seen in other conditions, so aortic, it can happen to the aorta as well. Pressure changes also cause a problem, so if the bowel suddenly increases in pressure, it can essentially pop. And patients can also develop fractures, so fractures of the ribs, which can then end up lacerating other organs. And this is something that's called Seatbelt sign, and it's fairly commonly seen in severe abdominal trauma. And the importance is that although it's not particularly sensitive, it's very specific. So a lot of patients who do have abdominal trauma won't come in with a seatbelt sign. But if a patient does come in with a seatbelt sign, you'll know that they've been damaged quite severely. And essentially all it is that you can see the seatbelt and you can see the bruising behind it. And it can happen if they've just got a lap belt on as well, you'll see the bruising behind the lap belt. So the features, the first one to consider is peritonism, and this is usually a consequence of the bowel popping or rupturing and ending up with fecal kind of contents all over the place. This can obviously irritate the peritoneum and lead to peritonism. And some of the features that you might notice with that are tender palpation, reband tenderness, and having abdominal guarding. The second consequence is hemorrhage, so there are obviously a lot of vessels within the abdomen, and many of these are actually communicated through the mesentery. So the mesenteries and the ligaments, as we said, were stalks, and one of their key roles is communicating the nerves and the arteries and the veins to and from the body wall to the organs. And a consequence of hemorrhage, if the patient's bleeding quite severely, can lead to shock. So shock is when the patient's cardiac output isn't enough to manage the oxygen needs of the body. The problem with BHVMT, so blunt abdominal trauma essentially, is that features develop quite late because there's a lot of space in the abdomen. So for something like hemorrhage to develop to a point where it's clinically significant, it takes quite a while, and it will need kind of a keen-eyed clinician or a keen-eyed nurse to be able to pick it up. And the factors are also quite non-specific, as I said earlier. In a patient who's had a big car accident, they will have a lot of other problems. They'll have pains kind of in their legs, in their arms, in their head, as well as in their tummy. So they may not be picked up very quickly. So to diagnose BHVMT, the gold standard these days is a CT scan of the abdomen. And this scan here just shows how this kidney has been damaged. So this is the left kidney, and there is injury around it, and you can see what looks like blood. Penetrating trauma, it shows up a lot better than blunt trauma on the CT. So usually if there's a bullet, you'll be able to see that quite clearly because it's a bit of metal and it shows up very clearly on the CT scan. Whereas blunt abdominal trauma isn't quite as easily seen, but CT is still essentially the best test that we have available. And damage to solid organs is also quite a lot easier to pick up because in general bowel is quite hard to interpret on a CT anyway, and the damage that you see on solid organs is a lot more well demarcated than it would be in the bowel. Another test that we use is a fast ultrasound, and some of you might have come across this. Essentially, it's an ultrasound test that's done very quickly, and you look at 4 areas of the abdomen. And And the reason you pick these 4 areas are those are the areas where fluid can collect. And anywhere that fluid can collect, blood can collect. So if a patient's got blood in any of these areas, you need to find where the bleeding is coming from, and you can be quite confident that the patient has had quite a significant bleed somewhere. The 4 areas that we look at are the right upper quadrant, the left upper quadrant, so behind the liver and behind the spleen, the suprapubic, so it's essentially where you might have the patch of Douglas in a woman, or the rectovesical recess in men. And we also look at the subcostal areas, which is just below the ribs. Another test that you may not have heard of, and we don't come across very often now, and it's kind of gone a little out of fashion with the advent of CT, is something called Diagnostic Peritoneal Lavage. And this essentially means that it's a test used for diagnosis, and it consists of washing out, so that's what the lavage refers to, washing out the peritoneum. And the way it works is essentially invasively some fluid is put into the peritoneum, so within the intraperitoneal space. It's washed out, and then it's taken back out, and then it can be analysed. And if, as in that picture, it shows a lot of blood, you can again be quite confident that the patient has had a bleed. As we said, BHVMT is quite often missed. Even if there is bleeding, it's quite often missed because there's so much space in the abdomen. And in particular, if there's no bleeding, it's very difficult to pick up because of the non-specificity of the pain that the patients get. Usually there are 2 scenarios where a patient is picked up as having BHVMT. The first is where the patient's complaining of abdominal pain, something else is suspected. For example, they've injured their appendix or they've injured their liver. And once it's opened up, the surgeon will notice that the bowel or the mesentery is damaged. The second is that the patient is progressively deteriorating. So the patient may be on the ward or has just come into A&E. The situation isn't recognised as being as serious as it is. The patient steadily gets worse, the blood pressure goes down, the heart rate comes up, and then eventually someone realises that they've got quite a significant bleed coming from the abdomen. In terms of managing it, there are 2 different pathways, and it depends on if the patient's hemodynamically stable or not. So by hemodynamically stable, we mean is the patient in shock or not? So essentially, is the patient perfusing all of the organs or not? If the patient's hemodynamically stable, a CT scan is recommended in the UK. If it shows no intra-abdominal injury, we're quite confident that CT scans are quite sensitive at picking it up, and we're happy to just monitor the patient. If it does show that there's injury, there are 3 options, and this is a common theme that you might have noticed during surgery. So the first option is always kind of medical, non-operative management, so conservative treatment. And this essentially involves giving the patient some painkillers, keeping an eye on their obs, and making sure they don't deteriorate further. Another technique that's used is something called RABOON, and it means resuscitative endovascular balloon. And endovascular essentially means within a vessel, and resuscitative means that it's done for the purpose of resuscitating the patient. And balloon is a balloon. And I'll come on to what this is. And then the third and probably the most radical option is to resect the bit of the bowel or the mesentery that's bleeding. So you cut it out, stop the bleeding, and patch the patient back on. So RABOON is a technique usually I think done by interventional radiologists here. And what it involves is putting a wire up into the groin, passing it up through to the abdominal aorta, and once the wire is in, a catheter is also put up behind it. So a wire is just as you would have any normal wire, except it costs a lot more. And a catheter is something that slides over it. So like a cannula, you have a needle and a catheter that slides over it. It's the same in this. So you pull the wire out, and then you can inflate a balloon. And the whole purpose of this is to intentionally cause blood flow to the abdomen to stop. And you stop the blood flow, you stop the bleeding, and then eventually you can remove the balloon once the patient is stabilised. If a patient's hemodynamically unstable, so if they've bled loads and they've got blood everywhere and they're in shock, we usually do an ultrasound, so a fast scan, and this will identify the blood within the abdomen. If there is blood within the abdomen, the guidance is to take the patient straight for an emergency laparotomy because they're hemodynamically unstable. We need to stop the bleed. If there's no free fluid, we're usually convinced that there isn't a bleed in the abdomen because ultrasound is quite sensitive, and if it says that there isn't a bleed, it's usually quite good at predicting that there isn't a bleed. So we look for other causes of the patient's hemodynamic instability. For example, have they got a bleed in the thorax or elsewhere?